Thank you. If everyone can take a seat, please. Huge thanks to Tim O'Brien for gathering everyone back for this next session, which I'm excited to present on behalf of my co-chair, Dr. Lisa Henske, and myself. So the last few years have really seen incredible insights into biology of kidney cancer published, and there is huge hope now that we might be able to apply some of this knowledge in the clinic. And congratulations to the organizing committee for putting together this excellent and very diverse session, which we look forward to moderating. So first of all, I'd like to invite to the stage Dr. Ferran Herrera from Barcelona. I very much look forward to your presentation on the WHO classification. Thank you.
First of all, thank you for your kind invitation to join you. But I'm just a pathologist, which means that the treatment is out of my topic, but it's not true. What is the objective of this presentation? To try to integrate this new classification with the ESMO guidelines, the current ESMO guidelines, and to consider the possibility of another pathways. And I would like to start with this idea. What is a classification? A classification is just to look for different categories with one idea. In pathology, in medicine, the idea is good. The patient, the evolution of the patient, and the treatment. That means that depending on the treatments, we can change the classification. This can explain why WHO classification from 2004 until now is increasing in number of entities. That means that appear new entities. No, we read the same entities with another book, with molecular and with the possibility of treatments. That means that this is the recent classification, more than 20 entities with different molecular pathways. And I would like to consider the introduction of this in the idea of clear cell carcinomas, papillary carcinomas, chromophore renal cell carcinoma, and so on. That is the guidelines of the ESMO. First idea, not all clear renal cell or not all renal cell carcinomas with clear cells are the same. And this is the topic in all the ideas. Of course, the majority of the tumors are the classical clear cell renal cell carcinoma. And this is the truth. And this is very important because with the old ideas continues working. But even among the patients with clear cell renal cell carcinoma, there are the possibility of different molecular subtypes, depending if to remove only the von Hippel-Lindau gene or remove also the BAT or the Z2 and so on. And even in morphology, it's difficult to distinguish. Probably this can explain why in clear cell renal cell carcinoma, the molecular signatures can help in the election of the treatments. As a curiosity, there are some cases without the election in short arm chromosome 3, only in large arm of chromosome 8, that looks the same. But this is a curiosity, only 20 cases. But the most important is that among tumors with clear cells, there are cases with indolent evolution. One, around 2%, is this multilocular cystic renal neoplasm that has lesions or loss of chromosome or gene, von Hippel-Lindau gene, but another ones. If we use a very strict criteria for this, these are completely indolent tumors. But for me, it's more important even the clear cell papillary tumor. The name is not correct for my idea because the majority of the cases has tubular more than papillary. But this is clear cells without any relation with papillary renal cell carcinoma, with any relation with clear cell carcinoma, classical clear cell carcinoma, and without alterations in von Hippel-Lindau, and represents, at least in our knowledge now, 3%. 3%. Well, this is a summary that I can explain. Well, what happened, the papillary pattern is very important, this aspect, because not all tumors with papillary pattern are papillary renal cell carcinoma. The papillary renal cell carcinoma, classical, is the low-grade papillary renal cell carcinoma that was the former type 1. But we prefer at this moment low-grade papillary renal cell carcinoma that has in the sporadic cases with loss of c-MET in around 30%. But it's very interesting that there are some subtype inside this low-grade renal cell carcinoma, papillary renal cell carcinoma, that has more frequently loss of this loss of c-MET, that is this biphasic scamoid, and even one that is very interesting historically for us, because for a long time, many pathologies was considered as high-grade or type 2 papillary renal cell carcinoma, that this is with inverse or reverse polarity that has mutations in KRAS. What happened with the type 2 papillary renal cell carcinoma, now high-grade papillary renal cell carcinoma? We don't know what happened. Because for a long time, we included inside this entity other entities that we know now that represents another pathways, as the renal cell carcinoma with papillary pattern, but is fumarate hydratase deficient carcinoma. Very aggressive, and it's possible to identify by immunohistochemistry with demonstration that this deficient fumarate hydratase. And another, the translocation. Some translocations has a very papillary pattern, especially the TFE3 rearranged renal cell carcinoma. That means that in this moment, we need to distinguish the high-grade former type 2 papillary renal cell carcinoma from these other entities with completely different pathways and possibly completely different future or present treatments. This is your topic, not my topic. What happened with the chromophore renal cell carcinoma? Chromophore renal cell carcinoma has a big problem with the oncocytoma and chromophore renal cell carcinoma. But avoiding this topic, because it's another topic, there are some renal cell carcinoma with eosinophilic or chromophore-like aspect that has indolent evolution, the same as the succinyl dehydrogenase deficient carcinoma, the case of eosinophilic solid and cystic renal cell carcinoma, some of the cases in relation with the tuberous sclerosis genes, the renal cell carcinoma associated with acquired cystic disease, but less frequent, and not only this entity can be associated with acquired cystic disease, and the tubulocystic renal cell carcinomas. Those are indolent and has different pathways. And we must distinguish from chromophore renal cell carcinoma. What happened with the spindle carcinomas? Not all the spindle are sarcomatoid, because there are spindle low-grade, as the entity mucinous, tubular, and spindle renal cell carcinoma. Very infrequent, yes. Similar to papillary low-grade, yes, but completely different to real sarcomatoid. That is important. And entering in the topic of sarcomatoid, it's important to remember that all the entities that I explained can be areas with sarcomatoid transformation. The problem is the percentage. 100%, of course, 80% is important. But 20%, 10%, who knows? This belongs one entity of sarcomatoid. You need to treat as sarcomatoid? I don't know. I think nobody knows exactly. In some papers said 30%. Well, I don't know it's true. The other aspect is there are some sarcomatoids at the beginning. The ALK is very recent entity, and the others medullary and collecting duct carcinoma, and has different pathways once again. Well, what is the future? I don't know, of course, but probably follow the same line, the same guide. Look for different markers and the possibility of different molecular changes that has some possibility of treatments. In conclusion, similar morphological variants of renal cell carcinoma has different molecular pathways and probably different therapeutic targets. And a provocative idea. Therefore, be careful in the moment to indication one treatment or another, and probably to change in the future some of the present or current guidelines. I think that the topic is so wide, and it's necessary to explain many things. And I hope that the next speakers, not all today, tomorrow also, can explain some aspects of these different entities. Thank you.
Thank you, Dr. Araya. Our next speaker, I'm pleased to introduce Dr. Payal Kapoor from UT Southwestern Hospital, who will talk about AI and digital pathology, new tools in RCC. Thank you, Payal.
Good morning, everyone. I want to thank the organizers for inviting me. It's a pleasure, and I'm delighted to be here to share some of our work in digital pathology. So I want to start by thanking and acknowledging the people who've done the work, even though I stand and present to you. Today, I will be sharing 4 projects, 3 of which are on digital pathology, spearheaded by Sathwik Rajaram. And then I'll like to end with our efforts in having a pipeline for having a kidney cancer database, which was spearheaded by Venkat. And also wanted to thank our collaborators, both Genentech and Mayo Clinic, for sharing their slides. So work from a large group of people have shown that driver mutations such as PBRM1, SETD2, and BAP1 have influenced outcome. We asked if that was true for morphology, whether these mutations influenced morphology. Therefore, we developed some deep learning models that could predict the status of these mutations from H&E slides alone. We used a large cohort of over 1,000 slides in collaboration with Mayo Clinic, for which we knew the status of PBRM1, BAP1, and SETD2 based on IHC. To test these models, we applied it to multiple different cohorts, including PDXs. For each gene, these models were to predict on 2 levels. At a slide level to mimic a whole genome expression, and at a regional level to resolve intratumoral heterogeneity. As you can see here, on whole slide predictions, all 3 genes had an outstanding performance. But this was particularly so for BAP1. And as you can see, it had one of the best performances across any genes published for cancer. Particularly, this model had a very high negative predictive value, as you can see by that flattening of the curve on the right side. And this is true for looking at these slides through IHC. I can, with high confidence, feel sure that this particular slide would not have BAP1 loss. Feel less confident, though I think, predict that it would have BAP1 loss, but it's harder for especially SETD2 and a little bit so for PBRM1 also. At a regional level, the predictions remained highly sensitive, as you can see here by the solid line, and also for PDX models. It's interesting that it remains predictive for PDXs where the stroma gets replaced by the mouse stroma, so these properties are largely tumor intrinsic. Since BAP1 correlates with both grade and outcome, we asked if these predictions correlated too. And as you can see here, that the BAP1 loss correlated with increased grade and captured BAP1 signature information beyond the grade. And also that the survival stratification based on true and predictive BAP1 were highly comparable, if not better. However, the intratumoral heterogeneity that's so characteristically seen in clear cell RCC is likely an outcome of more than one gene, as beautifully illustrated by multi-regional sequencing from Samra's group, and has been recognized for decades by pathologists. Our group used an ontologic classification to describe the phenotypic heterogeneity of clear cell RCC and proposed an evolutionary model based on tumor grade and size to depict the evolution. In order to validate this, we obtained a morphologic-guided multi-regional sequencing from 27 different patients, including more than 250 different regions. We also developed a model very similar to face recognition that could give a probability score for similarity between different patches based on their morphology. We found that the score from this morphosim model correlated with the patterns that we had described as shown in the right. Further, we found that it also correlated with biological states such as by grade, HIV status, CD31, and BAP1, as you can see on the left. Further, we are now finding for majority of the cases, the evolution that we had shown based on morphology is correlating with the genetic tree based on the mutation status. And here's an example from one patient that I show. And this is a work in progress. It's very interesting that the drugs that we use to treat clear cell RCC either target vasculature or immune cells and not the tumor cells itself. And work from iMotion 150 and 151 have shown that the gene expression correlates, gene expression of the angioscore and the immune effector cells correlates with response to these therapies, and also correlates to the expression of these corresponding cells based on CD31 expression by IHC and CD8 by IHC. Given the clinical significance of having such a predictive model, the fact that gene expression is subject to intratumoral heterogeneity and therefore limited by that, and that these endothelial cells, which give the angioscore, and immune cells are easily seen on H&E slides, we tasked ourselves to build a model that could predict the angioscore and T effector score from H&E slides itself without the need for sequencing. I'm going to share the data for the angio score with you, because we are ready to send it for publication, but similar effort is ongoing for T effector score. So here what I'm showing you is the prediction of angio score based on H&E slide alone and its correlation with angio score for RNA score. And there are 3 different previously not seen cohorts that I'm showing you here. And as you can see that the correlation is outstanding. And this is particularly so for the iMotion 150, where the H&E slides were flanking the tissue that was used for RNA-seq and gets a little bit less when that's not the case. This angioscore prediction from H&E slides alone outperformed that seen from CD31 expression when compared to RNA-seq, as shown here for 2 different cohorts. Here I'm showing you just the iMotion 150. It also correlated with the NMF clusters from iMotion 151 on both the UT Southwestern and the iMotion 150 cohort. We also asked if these predictions correlated with prognostic factors, and indeed, it inversely correlated with stage grade and also beautifully with overall survival, as shown by this Kaplan-Meier curve for the UT Southwestern cohort. But more importantly, the predictions also correlated with response to frontline angiogenic therapy in a real-world data from UT Southwestern, and also in the iMotion 150. On the top, I show the predictions from H&E slides, and bottom is the from RNA data, and you're very familiar with that iMotion 150 data. And as you can see, the predictions are very similar. So basically, in these three projects, what I've shown is that morphology is a phenotypic reflection of the underlying genome and transcriptome and is a really good surrogate. And here's a slide that shows this intratumoral heterogeneity. Sathwik has built models that can easily predict what is the tumor, the different clones that are there, just on a click of a slide. These clones, as you can see, are associated with different immune environment, just going higher par to show the different clones. And we can see that they also have different immune cells and vasculature. So the green is the intrinsic vasculature there. The blue was the immune cells. And this is histology showing the difference in morphology. And also segmentation for nucleus, which is just tumor specific and not the tumor environment. I'm going to switch gears now and pivot to the fourth project that I wanted to share, where we have, in the pre-COVID time, partnered with our bioinformatics team in building a pipeline that can curate kidney-specific data from our EMRs and integrate it together to build a database. The advantage of such a pipeline is that it not only allows for very high accuracy, but it also allows for having longitudinal data that can easily be scaled up. The biggest limitation of such a pipeline is that a lot of our data exists not as free text, not as discrete fields. What we did was to overcome this was to build a custom natural language processing system for our pathology data for all the pathology outputs, metastasis, immunohistochemistry, nephrectomy. And we found that we were able to capture 33% more metastatic pathology cases by using this tool than that were available in our tumor registry or by manually extracted data sets by our urology and hem-onc fellows. So there are ongoing efforts now going to integrate this with our huge amount of sample inventory, which includes live biobank, tissue preserved in DMSO, our large tumor graft platform where there are drug trials on the engrafted lines, our extensive genetic data that is available, and also the large volume of both radiology and pathology slides that are available with the goal of having this comprehensive kidney cancer medical intelligence enterprise where now we can apply artificial intelligence and ask questions that would otherwise not be possible. Thank you for your attention.
Thank you very much, Payal, for a fabulous talk. Next speaker needs no introduction to this audience. It's Mike Atkins from Georgetown University. Thank you.
I'd like to thank the organizers for inviting me to, it's not my slides. Can you bring up the slides for Atkins? So as I was saying, I'd like to thank the organizers for inviting me to give this third talk today, and hopefully I'm going to try to fit it into this session because it doesn't completely fit into the session. And I'm going to talk about this phase 2 trial that we recently published clinical data on and focus on some of the correlatives. So these are my learning objectives to begin to talk about some of the biomarkers related to this trial and then also describe the treatment-free survival results. So this is the trial. Patients with treatment-naive clear cell kidney cancer underwent a biopsy of a metastatic lesion within a year of treatment and then went on to receive nivo monotherapy for up to 96 total weeks. And if they had disease progression or stable disease as their best response at a year, they had another biopsy to confirm there was tumor there. And if there was, they went on to receive a nivo-ipi boost. And So this is the clinical data that's been published. You'll see the overall response rate was 34%. And I call your attention to the waterfall plot on the left for favorable risk, where there was a 57% response rate for the favorable risk patients and 25% response rate for the rest of the patients. And for overall, the median duration of response was about 27 months, so maybe a little less than what we see with Nivo/Ipi, but for the favorable risk patients over here on the right, 17 out of 20 responders were ongoing. So now to the biomarker data. We looked at PD-L1 staining on the initial biopsies, and that's shown here, broken down by PD-L1 categories. And as you can see, majority of patients, of the 102 patients, had no PD-L1 staining, but as in the 24 patients who did have PD-L1 staining, as it got higher and higher, the response rate got higher. And that data is just shown here in this waterfall plot, where 6 out of 8 patients with high PD-L1 status had a response. In addition, this high PD-L1 status was significantly associated with landmark PFS at a year. So why didn't other studies with kidney cancer show this association with PD-L1? Well, a lot of those other studies, the analysis is on the primary tumor rather than metastatic lesions. They were using samples that were older than a year before treatment initiation or after another intervening, or that were collected before another intervening treatment. And they also were looking at time to event endpoints such as PFS or overall survival rather than response rate or landmark PFS, which are better measures of immunotherapy. And most importantly, they were looking at combination regimens which didn't isolate the impact of an anti-PD-L1 component of that regimen. And many times, rather than comparing within the treatment group, they were trying to compare to another treatment group, which can be confusing. And this study avoided all of these issues and reveals this association of PD-L1 expression with nivolumab efficacy, which is not useful clinically because it's too small a group of patients to actually make decisions on. However, it could be useful for a biomarker model. And so we're taking those biopsies that we did before treatment and the ones, pairing them with the ones in resistance, and we're doing whole exome sequencing, RNA-seq, and single-cell RNA-seq because of fresh biopsies. And we've come up with 2 other biomarkers, SLAM-F7 by single-cell RNA-seq, in work that David Braun has been doing as part of a grant we have together, and then PD-1 expression on Tregs in work done by Sabina Signoretti and Arlene Sharp. And I call your attention to this publication that says that SLAM-F7 signaling reprograms T cells towards exhaustion. And I'm just going to focus on a little bit of the SLAM-F7 data. This is data showing that patients with progressive disease had much higher expression of SLAM-F7 on their CD8 T cells, and this was clinically meaningful because there was higher progression-free survival in the group of patients who had low SLAM-F7 and higher overall survival. And then what Dr. Braun did, rather than just compare it to all of our single-cell RNA-seq data, or all of our RNA-seq data from this study, he compared it to signatures they had from Checkmate 09 and Checkmate 25, and saw that there was an association of poor overall survival with SLAM-F7 expression. And we're now in the process of refining this signature and going back to look at the rest of our data. Now I'm going to switch gears and talk about the TFS analysis, and that's treatment-free survival. And we know that immune therapy can produce these periods of treatment-free survival and toxicity that exists after treatment stops. And we have shown that that can be meaningful in our analysis of patients receiving nivo-ipi in melanoma or kidney cancer. But all of those analyses were complicated by the fact that there was no firm ending to treatment. And so therefore we sought to assess TFS in this trial, which was designed to reduce toxicity by limiting exposure to CTLA-4 blockade and cap therapy duration at 96 weeks. So here's the same trial design, but I just call your attention to over at the right where the treatment-free survival period is demarcated by the arrows. And this period begins when treatment stops for either toxicity or progressive disease or treatment completion. So for Part A, that was a maximum of 96 weeks. For Part A going to Part B, it could go up to 108 weeks. And it ends when the start of subsequent therapy happens or death. And so we define TFS as the area between Kaplan-Meier curves for time from registration to protocol therapy cessation or time from registration to subsequent treatment initiation, both estimated for a 36-month mean time. And then we captured time on or off treatment with grade 3+ treatment related adverse events. So this is a relook at the clinical data, now 128 patients. Now we combined both the initial treatment and the boost as one regimen, and you can see slightly different response data. But I call your attention to the 3-year endpoints from the Kaplan-Meier curves, where you can see that for overall survival, 68% of patients were alive at 3 years, and 38% of patients were alive and subsequent treatment-free. And you can sort of see those endpoints at the right of this Kaplan-Meier curves that were laid out here in the circles, and you can also see that all patients had stopped treatment as was planned in this particular protocol. But I want to now show you this same curve and highlight the treatment-free survival characteristics, which now focuses on the area beneath or between these curves. So here the overall survival is 29.9% of the total, 29.9 months or 83% of the total 36-month period. And that's divided by time on treatment in purple, treatment-free survival in blue, and survival after subsequent treatment in gray. That adds up to the total overall survival. And if we look for the favorable risk patients, you see this sharp drop-off at 96 weeks where treatment stopped. You can see the treatment-free survival was 12.9 months, the period in blue, and that 65% of patients were alive and subsequent treatment-free at the 3-year mark. And interestingly enough, 99% of the time for these favorable risk patients was spent alive, with only one patient having died in the favorable risk group. And for the intermediate and poor risk, treatment-free survival was 8 months, and overall survival was 27.4 months. So all of that is shown here in this table. I call your attention to the TFS data for these various risks and show that the treatment-free survival amounts were longer than what was seen in Checkmate 214, highlighting the impact of having an endpoint for your treatments. And I also call your attention to the time spent with toxicity, which was a very small percentage of the treatment-free survival time, somewhere between 3 and 4%, or about 1.5 out of the 36 months. So looking at this treatment-free survival analysis, we can sum it up and conclude that this captures this valuable information about how overall survival time is spent that's not contained in the traditional trial endpoints, and it was particularly noted in patients with favorable risk disease, further supporting the use of an immunotherapy-only regimen in this population, something we'll come back to later today. These are my take-home messages, and you can quickly read them here, and then I will stop by hopefully, well, I thought I was going to thank all the people involved, but I can't get to the next, oh, here it is. Acknowledging all the people involved in this trial, our funding sources, and of course the patients and families who participated in this study. Thank you very much.
Thank you very much, Mike. Our next speaker is Jessica Downs from the Institute for Cancer Research in London, and she'll be talking about epigenetic regulation by PBRM1 in clear cell renal cell carcinoma. Thank you, Jessica.
Thank you. Thanks to the organizers. It's a real pleasure to be here. So what I'm going to tell you about in the next 10 minutes is a little bit about the PBRM1 protein, which my lab has been studying for the last 20 years or so, and of course how it's important in clear cell renal cancer. Right. So what I want to do is actually just kind of give a very brief overview about what this protein does and focus on some of its cellular functions and how these might then impact on the response to immune checkpoint inhibitor therapy in the clinic. Okay. So as you know, this is an early event, loss of function. Mutations in PBRM1 is an early event in renal cancer, and of course, somewhere around 40% of patients will have no PBRM1 expression, and a lot more granularity and depth came out of a very nice study from Sammer's lab a few years ago in the TRACER-X renal study, looking at the evolution trajectories of these patients and how frequently you see PBRM1 and what it's commonly associated with. But very clearly, it's actually an important player in renal cancer, and indeed in mouse models, loss of VHL and PBRM1 alone can drive clear cell renal cancer. So what is it doing, and why is it so important? What happens in the cells when it's gone? So PBRM1 is part of the PBAF chromatin remodeling complex. And as you can see here from the schematics, this is one of 3 very related SWI/SNF chromatin remodeling complexes that are very conserved in mammalian cells and very highly expressed throughout all tissues. They share a lot of components and share structure and function. As you can see, the gray subunits are shared between them, but there are sort of complex specific subunits, and PBRM1 is one of the subunits that is unique to the PBAF remodeling complex. And these complexes, by virtue of deriving energy from ATP hydrolysis, just change the nature of the relationship between histones and DNA. PBRM1 predominantly slides nucleosomes, or can also evict nucleosomes. So of course it's making access to that DNA. So in the absence of PBRM1, which is a targeting mechanism of PBAF, the complex isn't going to the right places at the right time, so it's not providing access to the DNA in the right way. This, of course, has multiple different consequences, but it's important to consider that it's relevant, and I'll come back to this, to all DNA templated events in the cell. So we tend to think about gene expression, but it's also very important for DNA repair, DNA replication, and replication stress responses. Right, so cellular consequences. When you lose PBRM1, as I mentioned, obviously you've got a big consequence on gene expression. There have been loads of studies looking at this to see what the global pattern of misregulation is, and a few kind of common features that people have identified are that there are changes in hypoxia signaling, as well as, in many studies, changes in innate immune sensing, including interferon signaling. So the gene expression patterns change, and this obviously can impact on how these cells then behave and relate with their neighboring cells and with the immune system. But in addition, coming back to this idea that it's important also for other DNA templated events, we know that the genome integrity is compromised in the absence of PBRM1. It plays a key role in responding to DNA damage. And that includes the p53 response to DNA damage, but also there are multiple roles in the repair of double-strand breaks. And these breaks can arise both through exogenous treatments, such as ionizing radiation, but also, importantly, through replication stress, which, of course, is a feature of many cancer cells. So you can have breaks feeding into this pathway all of the time, and in the absence of PBRM1, there's a failure to deal with these. In addition, there's a compromised G2M checkpoint, so in response to DNA damage, these cells progress through mitosis inappropriately, and I'll come back to this. And finally, there's a really beautiful recent paper that came out of the Markowitz lab where they were looking at signatures of chromosome instability and found that PBRM1 loss is a genetic determinant of signature 1, which I can come back to if anyone's interested. So in addition to these cellular features, there have been a number of reports suggesting that PBRM1 loss correlates with response to immune checkpoint inhibitor treatment. But there are a number of these where they find a positive correlation and others where they don't. And so obviously one of the things that we wanted to think about from a cellular perspective was whether or not any of these features of PBRM1 loss might be relevant to whether or not PBRM1 deficient cancers are responding to ICI therapy. Okay, so as I mentioned, there's a defect in maintaining the G2M checkpoint in response to DNA damage. And this DNA damage can either be a result of exogenous sources, treatment, for example, but also a feature of replication stress-bearing cancer cells. And when that happens, they move through mitosis inappropriately, and that DNA then ends up in the cytosol, and this activates the cGAS-STING innate immune response pathway. So what we see in PBRM1 mutant cells is that they respond to damage not only by having increased genome instability, but also by having increased inflammatory signaling. And you can see here in these data, we actually were looking at some expression of some cytokines and interferon pathway members. So this raises the possibility that by pushing the system, by treating PBRM1 deficient cells with things that create this sort of problem, they'll move through mitosis inappropriately, activate this response, you increase inflammatory signaling. And this has been shown by in other studies to potentiate responses to immune checkpoint inhibitor therapy. So this combination could actually be quite important or something to consider. But in order for this to be the case, the DNA in the cytosol needs to be recognized by the cGAS-STING pathway in order to initiate this signaling cascade. So one of the things we wanted to do was to look back at some of the clinical trial data and see whether or not there was any relationship between PBRM1 mutational status, cGAS signaling, and outcome. And the reason for this is that cGAS expression levels are commonly downregulated or even lost in cancer samples or in cancer cells. So we did this. We actually went back and looked at a couple of different clinical trials. I'm just showing you one example here. We looked at the patients from the CheckMate trial. We stratified them first by PBRM1 mutational status, and what we found, which had already been reported, of course, was that, yes, the PBRM1 deficient patients tended to respond better. But as you can see, there were obviously still quite a few non-responders in that cohort. So we then looked at what the cGAS expression levels looked like in those patients. And what you can see is that there's a trend towards a decrease of cGAS expression in the PBRM1 mutant patients who didn't respond well to the immune checkpoint inhibitor treatment. So from these, the biomarker identification might not necessarily be critical in this case. It might be more important to think about what the cellular consequence is and how this is signaling to the innate immune system. But what it raises is the possibility that looking at both PBRM1 mutation levels and cGAS levels would be important to predict how they're going to respond. And it was just, I'm going to go through this very quickly, but it was of note that another group actually found that PARP1 levels, when combined with PBRM1 mutation status, also help to improve prediction to ICI checkpoint, ICI therapy response. And what's notable there is, first, we'd actually published a few years ago that PBRM1 deficient cells are actually selectively sensitive to PARP inhibitors. So that was notable. But also PARP, of course, is a sensor of DNA damage. So when you have low levels of PARP, you're not sensing and responding appropriately to that DNA damage, which is then being sort of inappropriately pushed through as the cells fail to maintain a G2M damage checkpoint in the absence of PBRM1, and you get increased levels of cytosolic signaling. Okay, so the take-home messages then are that PBRM1 loss leads to a number of cellular consequences that impact on genome integrity. And in the absence of PBRM1, you fail to maintain the G2M checkpoint. That means that the cells progress through mitosis with unrepaired damage. Cytosolic DNA then activates the cGAS-STING pathway and upregulates inflammatory signaling as a response. This could potentially lead to improved response to immune checkpoint inhibitor therapy. What's clear from the literature is that PBRM1 mutational status alone is insufficient to act as a single biomarker. But when we sort of think about the hypothesis about what's actually happening in these cells and why they might be responding or not, we could consider the use of things like cGAS levels or PARP levels as good candidates for combinatorial biomarkers. And one consideration for future studies is whether we push the system by creating DNA damage in PBRM1 deficient cancers, that then it wouldn't necessarily, the outcome that you're looking for isn't increased cell death, but rather an increase in the inflammatory signaling, which then can potentiate responses to things like immune checkpoint inhibitor therapy. Okay, and I'll just finish there by acknowledging all the people who are involved in this and the funders who were involved. The G2M damage study was done by an incredibly talented PhD student, Jeffrey Fung, who is in fact now a postdoc in Sammer's lab. And I'll stop there and thank you for your attention.
Thank you very much, Jessica. And now it's my pleasure to invite my co-chair, Lisa Henske, to present on the topic of non-clear cell RCC.
Thank you very much. I'm super happy to be here and tell you a little bit about non-clear cell kidney cancer from my perspective. So my learning objectives are to understand the links between the different types of non-clear cell and to think about how these links might catalyze clinical breakthroughs. Just to start by acknowledging the really exceptional people I'm very privileged to work with, including my colleague Carmen Priolo, who is my co-investigator on all these studies, and David Braun, now at Yale, and Tony Schwery. So as has already been mentioned, each time the WHO reclassifies non-clear cell, there are more of them. So there now are, I think, 20 different non-clear cell renal carcinomas. I'm going to be, these were already discussed in beautiful illustrations, but the ones that are in blue here are the ones that I'm going to be thinking about today, including chromophobe, some of the TSC-associated renal cell carcinomas, and the TFE3 and TFEB rearranged carcinomas. So how can we make progress? We have now clear cell where there has been a lot of progress and continues to be progress, but we have 20 others. At least. So one option is that to think, well, all these occur in the kidney. Maybe if we try the therapies that work so well for clear cell, we might make progress in non-clear cell. A second option is to follow the clear cell pathway, to go from very basic discovery through preclinical models to clinical trials. And that's obviously worked extremely well in clear cell carcinoma, but the timeline is long and the complexity is huge if we have 20 different types. So a third possibility, which I'm sure has occurred to everyone here already, is that we might find common themes that have therapeutic relevance. And I'm going to talk about 3 of those today. The first are TSC1 and TSC2 mutations and mTOR activation. The second is TFEB and TFE3 as drivers. And the third is the intercalated cell of origin. The intercalated cell is the coolest cell in the kidney, and I'll tell you a little bit more about it in a moment. So I came to this from the background of tuberous sclerosis and Birt-Hogg-Debay syndrome, in which the renal cell carcinomas shown here have a very interesting pattern of chromophobe-like, or often have a pattern of chromophobe-like or hybrid oncocytic chromophobe morphology. As has already been mentioned, in TSC and BHD patients, we of course see these tumors, but mutations in these genes are not super frequent in sporadic renal cell carcinomas, but there are some exceptions. One is the eosinophilic, solid, and cystic renal cell carcinoma, in which 90% or more have mutations in TSC1 or TSC2, and renal cell carcinoma with leiomyomatous stroma. and eosinophilic vacuolated tumors. So there is a small but important subset of non-clear cell cancers that very typically have mutations in TSC1 or TSC2 or other mTOR pathway activations. So I'm now going to turn from thinking about the way we can link different tumors by their TSC1 and TSC2 mutational status to thinking about TFEB and TFE3 as drivers of not only tumors that are classified as having translocations, but perhaps other subtypes of non-clear cell. And as you know, the TFEB and TFE3 transcription factors are master regulators of the lysosome and autophagy, and also play a role themselves in mTOR activation. So we've found that TFEB and TFE3 strongly localize to the nucleus in TSC1 and TSC2 deficient cells, and you can see some of this here using a GFP-tagged TFEB reporter. We also see increased activity of luciferase reporters for TFEB and TFE3 in TSC1 and TSC2 deficient cells, and also in folliculin deficient cells. Folliculin is the causative gene of Birt-Hogg-Debay syndrome, suggesting that TFEB and TFE3 are hyperactive in both of these tumor situations. So potentially linking TFEB and TFE3 to tumors that have mTOR pathway activation. And in fact, in an unpublished mouse model of tuberous sclerosis-associated kidney disease, you can see the massively enlarged kidney, the third one over, that has loss of the TSC2 protein with multiple cystic and solid lesions. The next one over is if we knock out both TSC2 and TFEB. These kidneys are normal. The mice breed normally. It basically fixes almost everything that's wrong with the TSC2 deficient kidney, suggesting that in mouse models of TSC, the TFEB gene is the key and essential driver of tumor formation. And you may know that exactly the same thing has been previously found by Andrea Belabio in mouse models of Birt-Hogg-Debay, showing here a mouse kidney with, at 3 different time points, P7, P14, and P21, with knockout of the folliculin gene, again, completely fixed by knockout of TFEB. So now I want to turn to chromophobe and see if that might also link into these pathways. And chromophobe arises from the intercalated cell, and it's really a very, very unusual tumor. It's hard for me, at least, to put all of these things together. These tumor cells are filled with mitochondria with a high rate of ND4 and ND5 mutations relative to other tumors. They very often have loss of one copy of whole chromosomes, particularly chromosomes 1, 2, 6, 10, 13, and 17, and they have relatively few driver mutations, about 30% in P53 and 10% in P10, and they arise from these really interesting intercalated cells. This is one patient who I follow who's 55 with a 15-centimeter chromophobe renal cell carcinoma that had spread to 3 out of 6 lymph nodes and extended into perirenal fat. Fortunately, she is still metastasis-free. So what about these intercalated cells? These are the life or death cells in your kidneys. So these cells are in the distal nephron and are responsible for acid-base regulation. And to do this, the proximal tubule cells have a very easy job of resorbing bicarbonate. These cells have a very hard job of actually secreting hydrogen ions into the urinary space in order to maintain your blood pH. Because of this very hard job of excreting hydrogen ions, these cells, intercalated cells, have many, many mitochondria. And when we did metabolomic profiling on chromophobes, we found that they have very, very high levels of glutathione, almost 50 or even higher than the adjacent normal kidney. So we also found that the cystine transporter, SLC7A11, is elevated in chromophobe relative to normal kidney using data from the TCGA. So if we know that there is very, very high GSH, glutathione, in chromophobes, what would happen if we were to deprive these cells of cysteine or cystine? You might imagine that they have very high glutathione, they might be very resistant to oxidative stress and the inability to make glutathione, or you might imagine that they need all that glutathione to survive, and that might force them into cell death. So we use the drug Erastin, or IKE, which inhibits the transporter. And what we found is that this drug inhibits the growth of the chromophobe renal cell carcinomas in vitro and in vivo, as shown here. And we see similar results if we knock down the transporter, and also similar results if we treat with the enzyme cystinase. So we think that chromophobe renal cell carcinomas have high ongoing oxidative stress, perhaps because of all these mitochondria that they have since they arose as intercalated cells. And this, if you expose them to anything that decreases their glutathione production, they undergo ferroptotic cell death. Ferroptosis was first, the term was coined in 2013 and is a form of cell death in which lipid peroxidation of the membrane results in a regulated form of cell death. So we believe that chromophobe renal cell carcinoma is hypersensitive to cysteine deprivation and undergoes ferroptotic cell death. And this could have therapeutic implications, as many different biotechs are working on ferroptotic inducing agents. So lastly, I want to just mention that a very careful proteomic analysis of chromophobe renal cell carcinomas revealed that the lysosome is the top pathway upregulated through a KEGG analysis. And that actually suggests that maybe, and since TFEB and TFE3 are key master regulators of the lysosome, maybe there actually is a link here between chromophobes and TFEB and TFE3. So what I've shown you is that intercalated cell of origin is one of the ways we can think about non-clear cell. We believe that the tumors in TSC and BHD, chromophobes, and perhaps also eosinophilic cystic and solid tumors arise from intercalated cells. That mTOR pathway mutations are another common link, and actually mTOR activation may be even a bigger link, and that TFEB and TFE3 may be key drivers of multiple subtypes of non-clear cell renal cell carcinoma. So my take-home messages are that in tuberous sclerosis and Birt-Hogg-Debye, we see these chromophobe-like tumors that require TFEB and TFE3 for growth. That in sporadic renal cell carcinomas, there are enormously high levels of glutathione that may indicate that these cells are hypersensitive to ferroptosis, as we've seen in the mouse models, and that TFEB and TFE3 may be a link between many different types of non-clear cell carcinoma. Thank you very much.
Thank you so much. Lisa's very enlightening, and our final speaker is Brad Leibovich. He'll tell us about sarcomatoid and rhabdoid, the differentiation. Thank you, Brad.
Thank you. It's a pleasure to be able to speak about this. I don't normally point this out, but if you look underneath my name, I have the honor of serving as the David C. Utes Endowed Professor of Urology, and I'll make it clear why I point that out in just a second. I'd like you at the end of this to be aware of the prognostic implications of sarcomatoid or rhabdoid differentiation and understand how that may have implications for your care of these patients. So the reason I bothered to point that out is that Dr. Utes is a senior author, Dr. Farrell was the pathologist, Dr. Utes was the urologist who first described the term sarcomatoid renal cell carcinoma. So I knew Dr. Utes, he passed away in 2011. And he would be very pleased to know that we're devoting some time to discussing this here today. So they originally described 43 cases. The sarcomatous change in kidney cancer had been described by people previously, but these were the authors that coined the term sarcomatoid differentiation. It would be remiss for me not to talk about the people that explained the rhabdoid features in renal cell carcinoma. So this is Gilkin and Humphrey. Their original manuscript, this is much more recent, in 2000 described the comparison for about 23 adult patients. I've highlighted that here relative to a bunch of pediatric patients, and showed, if you look at the bottom, a high likelihood of extrarenal tumor extension and a high cancer-specific mortality for patients with rhabdoid features in their renal cell carcinoma. So we talked a lot about the WHO criteria for kidney cancer, which I don't expect you to be able to read. It's on the left of this screen. In describing the histologic subtypes of kidney cancer, it's important to understand that sarcomatoid and rhabdoid features are not histologic subtypes. This is tumor dedifferentiation that can occur in all the various subtypes. I'm not a pathologist. This is what it looks like, I'm told, underneath the microscope. I look at these things with my pathologist every single time I remove one of them. You can see for that growth specimen for the sarcomatoid this very sort of infiltrative growth pattern, and we're going to come back to that in a second. So how often does this occur? It's about 10% of kidney cancers will have sarcomatoid and/or rhabdoid differentiation. These patients will frequently present with locally advanced disease and/or metastatic disease, and it's more common when you have sarcomatoid or rhabdoid differentiation than in its absence to present with locally advanced or metastatic disease. We'll go over some of the clues in the presentation that might give you an idea that a patient has this sort of tumor. There's no question these confer a worse prognosis than tumors that don't have them. They likely, in my opinion, represent a subset we should be treating with a very different approach. And the other thing that's important to recognize is that any amount of these variations in a tumor, which will be heterogeneous throughout the tumor, confers a bad prognosis. And because biopsy is sampling only a small area of our tumor, biopsy may not be a great way to figure out if you have sarcomatoid or rhabdoid features, as that's often missed in percutaneous biopsies. So what are some of the clues? On the left of your screen is a manuscript from our center with our radiologist describing MRI features. On the right of your screen is a different series describing CT features. In general, if you see a tumor that is indistinct, that has irregular edges, that is infiltrative in its growth pattern, you should think perhaps this may have sarcomatoid or rhabdoid differentiation. If you see a tumor with MRI that has areas of low T2 intensity, that's shown by the arrows in the left box on the left of your screen. So low T2 intensity in MRI is suggestive of a sarcomatoid tumor. In fact, these authors developed a model with low T2 intensity regional lymphadenopathy and evidence of clinical T4 having an area under the curve of 0.76 for predicting sarcomatoid histology. So what are the clues? Infiltrative tumor, a locally invasive tumor, so I don't need to tell the surgeons in the room that tumors that we see that don't have sarcomatoid differentiation tend to push things out of the way. Those that grab onto things next to them and are clinically T4, you should suspect this. Nodal involvement, hematogenous metastases, as I said, MRI with low T2 intensity, and we talked about irregular contour. If you happen to have multiple images, these things often grow rapidly. So what impact does this have on prognosis? Well, this is a series, all of these were reviewed by a single urologic pathologist, John Cheville from our center, and what you can see in the top of the Kaplan-Meier plot is various histologic subtypes, and then what those histologic subtypes look like if they have sarcomatoid features. So it doesn't matter if you're papillary chromophobe or clear cell, adding sarcomatoid to that confers bad prognosis, and it's an independent predictor of poor prognosis. This is another series looking at all grade 3s versus all grade 4s, and then those that are grade 4 with sarcomatoid features, rhabdoid features, or both. And rhabdoid is a little bit worse than grade 4 without rhabdoid. Sarcomatoid and rhabdoid is significantly worse. Another series from another institution showing that with rhabdoid features, you have over a 5-fold increased likelihood of kidney cancer death after adjusting for other features that are prognostic. More data from our center. This is looking at grade 4 without versus sarcomatoid features. So among all patients, sarcomatoid are 58% more likely to die from renal cell carcinoma. Among M0 patients, 82% more likely to die with sarcomatoid versus none. And in multivariable analysis, after adjusting for multiple other prognostic factors, every 10% increase in the amount of sarcomatoid features was associated with a 6% increased likelihood of death from renal cell carcinoma. If you have to pick up one paper to read that's relatively recent, a couple of years ago, that will give you the overall picture of what's going on with these tumors on a molecular level, I would say get this one. So if you look at the author list on your screen, this is a who's who of kidney cancer. There's way too much data in here for me to give you anything but a very brief overview. So genomic alterations, BAP1, NF2 alterations, CDKN2A, 2B deletions, and MYC amplifications seem to be some of the drivers of these sarcomatoid and rhabdoid tumors at the genomic level. On the transcriptional level, when they looked at RNA-seq, high expression of MYC targets was associated with worse outcomes, didn't matter which patient cohort they looked at. They also were able to review data showing that sarcomatoid and rhabdoid tumors have an immune-inflamed phenotype, and they have higher amounts of tumor-infiltrating lymphocytes, higher PD-L1 expression, and increased antigen presentation. And you can see in the Harvard cohort, IMDC cohort, and they showed other cohorts, the impact that this has had with the patients receiving in red immune checkpoint inhibitors versus those treating otherwise, giving us a clue as to why immune checkpoint inhibitors may be useful for these patients. This is a series from Memorial Sloan Kettering and Mayo Clinic showing a particular subset of patients with sarcomatoid transformation that have these 9p amplifications, which result in constitutive expression of PD-L1, again, getting to a molecular classification of these tumors. How does this impact our therapy? So you saw this Kaplan-Meier plot earlier when we were talking about adjuvant pembrolizumab this morning, and this was presented at GU ASCO last year, showing that with sarcomatoid histology on the right of your screen, there is a phenomenal impact of adjuvant pembrolizumab in improving survival with a hazard ratio of 0.54. Do we do cytoreductive nephrectomy in these patients? I would argue if you know up front that a patient has sarcomatoid histology, you should not. So this is data from Brian Schuch and the group at UCLA showing that patients that have upfront cytoreduction in red that have sarcomatoid features do very poorly with a median survival of 4.9 months, and they are less likely to receive systemic therapy because of the rapid progression. This is the post hoc analysis. Dr. Tanier sitting in the front row here, first author in this of Checkmate 214, showing that for patients with sarcomatoid renal cell carcinoma, Nivo-IPI has a dramatic benefit in improving survival in patients with metastatic disease. I'm going to show this case super quickly. I'm out of time. This is a 71-year-old male with locally advanced and metastatic disease. He had a biopsy showing rhabdoid. He was started on actually pembrolizumab, and he had, as you can see, looking at the very right versus the very left of the screen, a significant response in his tumor. Tumor was actually resected. I don't know if that was the right thing to do, but it was the patient's wish, and we did take out his tumor, and he's remained free of disease. Take-home messages. This is not reliably predicted by biopsy, so you need to look for the other clues that I mentioned. We clearly need better ways to diagnose this up front. Rhabdoid and/or sarcomatoid features are associated with aggressive behavior of these tumors. For these M0 patients, they are probably the ideal candidates for adjuvant pembrolizumab. And for the M1 patients, I don't really know what the role is of surgery, but clearly we are benefiting these patients by the use of our immune checkpoint blockade drugs. Thank you very much for your attention.
Thank you very much, and thank you to all the speakers for really wonderful presentations. We won't have time for questions right now, but I hope you will keep your questions for lively discussion during the breaks. Oh, I'm actually, Michael is saying we have 5 minutes for questions. Wonderful, wonderful, thank you. So I would ask people with questions to please come to the microphones and introduce yourselves.
Yeah, please.
Hi, my name's Kate. Is it on? Yes. Okay. Hello, my name's Kate Young from the Marsden. I was just going to ask, with regards to the biopsies and sarcomatoid, using the imaging techniques that you described with the MRI, can they be used to direct biopsies to get any yield on that?
Brad, could you just repeat the question?
Sure, so that I could, except the microphone's not working. Hello? So I'll yell. So I think the question was, can we use the radiographic findings to direct biopsies to do better? Okay. Hello? So the question was, can we use the radiographic features that I mentioned to direct biopsies to do better? Depending upon which series you look at, the success of biopsy predicting the final pathology having sarcomatoid or rhabdoid features is 5 to 15%, depending upon what series you look at. It's clear that doing more biopsies and getting various different areas of the tumor based on different radiographic appearances improves the yield, but it's not known yet whether or not things like focusing on the T2 low intensity versus other areas of the tumor would drive that, because it's the T2 low intensity does not necessarily correspond to the histologic areas of sarcomatous change. Does that answer your question? Okay.
Thank you. Gabrielle?
Yeah, I have a question to Dr. Atkins regarding the high rate of response to IO in favorable risk group. Basically, favorable risk group is usually enriched for endothelial cells, so it's more angiogenic tumors. It has been alluded to by Dr. Payal also. So I would like to have your input on why a tumor that is favorable risk with high angiogenesis level have good response to IO. Thank you.
Mike, could you repeat the question? Because I'm not sure how well the mics are
Sure.
working.
The question is, why did the favorable risk patients do so well in our trial, since a lot of the studies suggest that that population is enriched for an angiogenesis-driven biology, which theoretically would not respond as well. So first of all, we'll hopefully sort that out as we finish our analysis of our biomarkers for those patients. But historically, this was the patient population that responded best to interleukin-2. And if you look at the Emotion 150 data, although there is more angiogenesis biomarkers in the favorable risk than in the higher risk, there certainly are a portion of patients that have expression of both the immune phenotype and inflammatory markers. And I think we need to move away from using these clinical variables to choose who should be getting immunotherapy and move towards some of the tumor-based and maybe imaging-based biomarkers that were discussed in this session.
Thank you. Is there another question?
Another question. I don't know for who.
Good morning. I'm Bala, a medical oncologist from Glasgow, Beatson. Welcome to Scotland. Question to the panel generally. With the increasing awareness of the biology of the sarcomatoid and rhabdoid features, is there any role for monotherapy VEGF TKI in this group of patients?
I don't understand the question.
The question was, I have the microphone, so I'll repeat it. Given the biology of sarcomatoid cancers, is there any role for VEGF treatment in these patients? And Brad, you want to answer that?
You can.
Okay. Well, I think as shown in the data from Nizar Tanir's paper, if you look at what the results were of sunitinib in the control arm of a Checkmate 214 in the sarcomatoid population, it was awful. And so I think that the best immunotherapies are probably the treatment for those patients, which I think, as maybe get into later in the debate, I'm not sure what the TKI is adding in those patients in the combination regimens.
Thanks.
Maybe I could ask one last quick question of Mike. So Mike, it's obviously so important, the PD-L1 expression in the metastatic sites. What do you think is going to be the best way to assess that? Because it might be different in different metastatic sites. How are we going to move forward with that?
Well, first of all, I think the first thing is to look at, as we did in the HCRN model, look at biopsies of metastatic sites before patients have any treatment. And rather than looking at the primary and then looking how that correlates with second-line treatment. I think ultimately where things will go will be more complex immunohistochemistry that looks at not just PD-L1 expression on biopsies, but where it's being expressed. I showed a little bit, but didn't talk at all about expression of things on particular cells. And I think we'll also move towards signatures from RNA-seq that will link to what PD-L1 expression is.
Thank you.